Hello everyone, my name is Inês Miranda. I'm an internal medicine resident from Lisbon, Portugal. It's an honor to be here in MIRSIM for the first time, also as a participant in this very interesting contest. Thank you for the opportunity. The clinical case refers to a male patient, 85 years old, with excellent performance status, with his personal medical history. The patient presented to our hospital with 1 month worsening dyspnea in leg edema, with heart failure stigmata on presentation. An inaugural diagnosis of heart failure was suspected and investigation was conducted. Laboratory evaluation showed elevation of GNT-proBNP and low-level high-sensitivity cardiac troponin T. The electrocardiogram, as you can see, showed atrial fibrillation rhythm, already known, low-voltage QRS on limb bleeds, a QS pattern from V1 to V3, and electrical alternation. Transthoracic echocardiogram showed severe concentric left ventricle hypertrophy with preserved ejection fraction, with a grade 2 diastolic dysfunction and valvular fibrosis. Cardiac stress magnetic resonance imaging revealed the left ventricle with increased parietal thickness, a thickened aortic valve suggestive of aortic stenosis, mild pericardial effusion, and on T1 mapping there was increased extracellular volume. After gadolinium administration, there was auricular and ventricular diffuse delayed enhancement, these findings being notable features of myocardial infiltration by amyloids. Based on these clinical, laboratorial, and imaging results, the patient underwent a diagnostic workup for cardiac amyloidosis. We started with investigation of light chain amyloidosis. Serum immunofixation electrophoresis showed a small monoclonal immunoglobulin G lambda spike. Urine immunofixation and Bence-Jones protein were negative. Kappa lambda ratio was normal, beta-2 microglobulin was low, and the values of calcium and albumin were normal. The case was discussed with hematology, and a monoclonal gammopathy of indeterminate significance, IgG lambda, with low risk of progression was assumed given the hematological characteristics. We also proceed with the bone scintigraphy that showed an increased uptake of the radiopharmaceutical in the myocardium with the visual score 2. Given our high clinical suspicion of cardiac amyloidosis in the presence of a plasma cell dyscrasia, the patient underwent an endomyocardial biopsy that showed foci of amyloid substance deposits, Congo red and sodium sulfate Alcian blue positive, and a cardiac amyloidosis diagnosis was confirmed. Then we proceed with amyloid typing, first by immunohistochemistry that was positive for the immunomarkers of transthyretin and negative for light chains. The genetic analysis of the TTR gene showed no pathogenic variant. This is a wild-type form ATTR. We concluded amyloid typing with mass spectrometry that surprisingly showed an immunoglobulin pattern compatible with light chain amyloidosis with the predominance of lambda chains in addition to the deposition of transthyretin. With this, we assumed a dual-type cardiac amyloidosis, wild-type transthyretin amyloidosis, and amyloid light chain amyloidosis of lambda origin. During this year of investigation, the patient maintained excellent performance status with the New York Heart Association Class 1 besides cardiac biomarkers in ascending kinetics. The patient started treatment with the CGLT2 inhibitor and furosemide, and he was referred to hematology consultation with the plan of doing a bone marrow biopsy and defining treatment according to the results that we are still waiting due to unexpected circumstances. Just a quick recap about the topic. Cardiac amyloidosis is increasingly recognized as a cause of heart failure. The two most common forms are amyloid light chain and transthyretin amyloidosis. There are cardiac and extracardiac red flags that should raise the suspicion of systemic amyloidosis diagnosis, and the patient in this case report presented some of these features. Transthyretin amyloidosis diagnosis can be made by bone scintigraphy in some cases. However, tissue biopsy is mandatory in the presence of a plasma cell dyscrasia. Amyloid typing is vital due to different treatments and prognosis. Immunohistochemistry is the most widely used technique. However, mass spectrometry has recently become the gold standard for amyloid typing due to its higher diagnostic accuracy. The presence of a dual pathology, this is ATTR and AL amyloidosis in the same patient and affecting the heart, as presented in this case report, is a phenomenon rarely reported in the literature. I finished this presentation with 3 key messages to be learned from this case that can serve as future points for discussion. Cardiac amyloidosis diagnosis is no longer an academic exercise with the emergence of new therapeutic targets. Definitive typing of the amyloid is vital to establish a correct diagnosis and start appropriate therapy for patients. The advancement in diagnostic tools will likely disclose more of these mixed forms that will raise relevant issues for treatment strategies and will allow us to better understand this complex disease. These are the references. Thank you for your attention.
Well, this is quite something. Julian Dobranowski, do we have mass spectrometry in Hamilton? Do you know? If we suspect cardiac amyloidosis? Okay, well, we learned something then. Your patient was 84 years of age.
85.
You mentioned the treatment modalities. What are they?
So I was referring to, nowadays we have treatment modalities for transthyretin amyloidosis that act in different steps of the amyloidosis cascade, like genetic silencers that suppress the synthesis of transthyretin. But for now, we only have tafamidis, which is a drug that acts as a tetramer of that act as a stabilizer of the transthyretin tetramer. So basically, it delays its dissociation and its deposition.
And does it do something good to, the patient?
Yes, it was compared with placebo in patients with amyloid transthyretin cardiomyopathy. And basically, it was associated with a reduction in all-cause mortality, cardiovascular-related hospitalization, and also with the reduction of the decline in functional capacity and quality of life.
Well, thank you. Who thinks, hand up, who thinks that medicine used to be simpler? Okay. When we didn't know whom to give the case to, we gave it to Dr. Akbar Panju.
Thank you very much for an excellent presentation. As you said, you know, amyloidosis is now a treatable condition. Until recently, amyloidosis meant death. So in the past, amyloidosis was not treated, but now with the effective therapy, cardiac amyloidosis is a treatable condition. Now, over the years, we used to think of amyloidosis as either a primary or secondary amyloidosis. Primary amyloidosis, we don't know the cause, secondary from another chronic conditions. So are these two types of amyloidosis two different diseases, or is it the same disease coming in a different way?
I would say there are two different diseases.
And we have a treatment for both the diseases now. I know there's one treatment for one type of amyloidosis. I don't know which one, the AL or the trithyroid. Or is it the same treatment for both of them?
No, it's not the same treatment. That's why it's so challenging. Because to transthyretin, for now, at least in Portugal, the only drug approved is tafamidis. And for AL amyloidosis, we have stem cell transplants or chemotherapy regimens.
So it's important to know which amyloidosis you are treating.
It's really important to direct and the correct treatment.
Thank you.
Next.
Thanks. There'll be many 85-year-olds with a background of hypertension that come in with a presentation of heart failure and have a diagnosis of HFpEF, and it won't go much further. So I guess what should we be spotting that should trigger cardiac MRI, for example, which is done in the minority of patients still? Mm-hmm. What is it that should be the thing that makes us think, wait a minute, this could be amyloidosis?
We have a lot of factors that should raise the suspicion. Imaging is really important. In the echocardiogram, we have the left ventricle wall thickness, really usually asymmetric in the septum. And then cardiac MRI, you have the delayed enhancement of the gadolinium. It is a very specific sign of amyloid infiltration of the myocardium. And also the T1 mapping. It is a quantitative method that measures the extracellular space, that if it's increased, it signifies that it has amyloid deposition in that space.
Thank you.
It helps you to think about it.
Well, two more questions.
Okay. Thank you for this nice. Just when now amyloidosis AL developed secondary, it will not be a secondary to benign monoclonal gammopathy. It must be some myeloma-like.
Sorry, I didn't understand.
Is there any discussion with the hematology? Need
Oh,
for
yes.
bone marrow assessment or some
Well, we discussed the case since the beginning. At first, they didn't want to do the bone marrow biopsy because they didn't find it useful because the patient had that hematologic characteristics that were very suggestive of fungus. But then when we have the deposition of light chains, I think bone marrow biopsy is mandatory. However, the patient was hospitalized in another facility due to an orthopedic condition, so it delayed the diagnostic workup.
Unfortunately, last question.
There are some clinical clues to detect transthyretin amyloidosis, especially lumbar spinal stenosis
Yes.
and carpal tunnel syndrome. We did a best practice advisory in EPIC in our hospital and asked them to refer them to the amyloid clinic, and we found 10 cases within 3 months.
Yeah, it's true, yeah.
Thank you very much.
Thank you.
Thank you.